Hello and welcome to the Clinical Update podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Pat, editor of MIMS Learning, and I'm delighted to have our medical editor Sangeeta here with me.
Hi.
Today we're going to discuss an issue that frequently affects older people, although it's something that happens to us all from time to time, and this issue costs the health and care system in the UK a staggering £4.4 billion annually. But it's hard to tackle because the causes are so multifactorial and it's difficult to apply effective preventive measures. However, there is a lot that GPs can do as part of teamwork to address this problem. And I'm talking, as you've probably guessed, about falls in older people.
£4.4 billion is a lot of money, Pat. Where does this figure come from?
Well, it appears in a guidance document from the government's Office of Health Improvement and Disparities, which talks about fragility fractures. And these type of fractures are the ones that happen from relatively low-level trauma. They cost the UK £4.4 billion annually, of which £2 billion is related to hip fractures alone. Some more stats. In 2017 to 18, there were over 220,000 emergency hospital admissions related to falls among patients aged 65 and over, with just under 150,000 or 66% of these in patients aged 80 or over. And another report from Age Concern says that unlike strokes, transient ischemic attacks and heart attacks, which are decreasing, fractures from falls are on the rise.
I can see why the cases are on the rise with our growing aging population. So I looked into this, and according to a Public Health England consensus statement on falls and fractures published in 2017, the number of people aged 65 and older is projected to rise to more than 16 million by 2033. It's not a very cheerful picture, is it?
Well, I mean, it's good that people are living longer, but not so nice that quality of life might be severely reduced by a fall. But as I mentioned, there's a lot that GPs can do, and there's new nice guidance to be aware of. So let's have a look at the GP's role and tie in recommendations around falls assessment and how GP prescribing has an impact. GPs have to operate within the constraints of the 10-minute consultation, which doesn't allow time for a thorough discussion of falls and risk of falls. However, a GP practice will have multiple chances to see the same patient over time, which does offer some opportunities to address this issue. And what we're going to discuss here is drawn from a MIMS Learning module on recurrent falls in older people aimed at GPs, from NICE Guidelines on Falls, which came out in 2025, from a British Geriatrics Society guideline on prescribing, and from other MIMS Learning materials. So let's start with recommendations from our recurrent falls module, which was in fact a webinar, wasn't it, Sangeeta?
Yes, so this was a webinar as part of our MIMS Learning Live digital event series, and it featured Dr. Anna Steele, who's a consultant in geriatrics and general medicine at Barnet Hospital in London. She reminded us that people over the age of 65 have a 30% chance of falling at least once a year, and if they're over 80, that increases to a 50% chance. Falls cause physical harm, as we all know, but also Dr. Steele refers to a psychological element, whereby falls cause anxiety, understandably, which hinders recovery. Dr. Steele talks about some of the causes of falls in her talk, and let's discuss those in a short while, but one of the key points she makes is about exercise. She says people start to fall because of poor strength, cognition, vision and hearing, maybe also because of drinking alcohol, along with poor gait and balance. She says these factors accumulate, and especially if you had a fall once, you change your behavior and stop going out so much that you get deconditioned.
She particularly mentioned sitting down, didn't she, with each hour a day spent sitting representing an increased risk of sarcopenia or loss of muscle mass and an increased risk of falls.
Yes, and that led her to make some specific recommendations for older patients, even if at a low risk of falls, that they should get education about falls, prevention and exercise.
Well, that sounds helpful. And what about those at higher risk?
For those who are at an intermediate risk, they should be offered targeted exercise or a physiotherapy referral. That's to improve muscle balance and strength and reduce falls risk. The types of exercise that she recommended include balance and strength training. There is good evidence for Tai Chi, but other balance exercises also work. Strength and resistance training is good, including sitting to stand, squats, reaching with standing, and lots of others. Patients need to do 2 or more hours a week of this type of exercise and they need to keep it up. Dr. Steele recommends that GPs should think of an exercise intervention in the same way that they think about prescribing pharmacological therapy. Let's have a listen to a quick clip from her presentation.
So I would suggest exercise being treated as a drug. The patient needs the right program. There's no point in giving them stuff that's not achievable. They need to do what they can do, what's sort of practical from their perspective. And then we optimize it like we do any drug. We optimize the dose and regularity to suit them. We have to be realistic. There's always an ideal, but you've got to sort of work with what you've got. And the benefit does stop if we discontinue.
So interesting comments there from Dr. Steele. It appears that exercise at whatever level can be useful for everyone at risk of falls. I came across a report from the University of Southampton which says that exercise can reduce falls by 23%. So that's a very effective intervention. For those at highest risk of falls, Dr. Steele recommends a full multifactorial assessment, which might have to be done over 2 appointments. And her presentation has a really handy slide at about 10 minutes in, which lists all the factors that you could look at during such an assessment, although she says you'd need to pick out the main ones of relevance to the patient in front of you.
Yeah, and the NICE guidance on falls, which came out last year, has a similar list of factors to consider when assessing someone, and there are a lot, 16 in all, ranging from cardiovascular health to urinary continence and osteoporosis risk assessment.
Yes, there are lots of potential factors and it's worth having a look at the guidance to review them. But the really key thing that both Dr. Steele and the NICE guidance talk about, and which is within the scope of GP practice, is medication and medication review. Dr. Steele says that polypharmacy is one of the huge areas that geriatric specialists look at when considering falls risk. She refers to what she calls FRIDs, or fall risk increasing drugs. And she says that when she asks a patient about risk, 9 times out of 10, they'll choose a lower fall risk over, for example, cardiovascular protection. She says they care about their quality of life right now. She recommends a variety of deprescribing tools, including Stop Fall, Stop Start, Stop Frail, Beers criteria, medstopper.com, ACB calculator, Forta, and the web-based Meds 75 Plus guide. She suggests to clinicians who don't already use these tools to go online, play around and see what suits them best.
It seems like a lot of good tools out there for deprescribing. What about when the medications have been prescribed by someone else, such as a specialist? Does that affect how confident the GP might feel to make alterations?
I think it does, but Dr. Steele's take on this is that GPs and geriatricians are similar and that they don't just see one part of the person, they see everything. And she says she thinks GPs are in the best position to make those decisions, and the tools could give them more confidence in how to stop more of the patient's medications if they're contributing to their falls risk. And she actually goes further and says that some drugs may need to be stopped in a stepwise fashion, but not all, and patients may do better once medications are just stopped. So she encourages GPs to be a bit bold with stopping medications. The NICE guidance also recommends carrying out a structured medication review to identify any medications that may increase someone's risk of falls and considering adjusting those to reduce risk.
I think many GP practices are taking action on this already, and that they or their practice pharmacists are conducting reviews among older and frailer patients with a view to deprescribing wherever possible. We have a module on MIMS Learning written by pharmacist Laura Buckley about how to conduct a medication review. This says that patients should get a structured medication review if they are severely frail, housebound, and have had recent hospital admissions or falls. And more recently, on our sister publication MIMS, we covered a clinical guide from the British Geriatrics Society, or BGS, about pragmatic prescribing for older people with moderate to severe frailty. The guide itself is very concise, just 2 sides of A4, and it has some key messages about falls risk and prescribing.
Okay, so what are the messages?
So first, where antihypertensives are concerned, the guide says that falls, among other things, are a potential harm resulting from these medications. It recommends more lenient blood pressure targets for moderately frail patients, such as average systolic BP in the range of 140 to 160 mmHg. For severely frail patients, it advises deprescribing antihypertensives altogether, as harms are likely to exceed benefits.
Oh, that's interesting. And are there any other types of medication mentioned in the context of falls risk?
Yes, so with agents for type 2 diabetes, there is a risk of hyperglycemia, which can lead to a cognitive decline and or falls. So for people with moderate frailty, the BGS recommends an HbA1c target of 60 to 75 millimoles per mole, and for those with severe frailty, a simplified prescription that avoids symptomatic hypoglycemia. For those with cognitive impairment, it's best to try and limit exposure to anticholinergic medications and to evaluate the risk and benefit profile of any antipsychotic or sedative medications. For heart failure with reduced ejection fraction, falls are again a risk, so the BGS recommends limiting prescribing to fewer than the 4 pillars of heart failure treatment for those with moderate frailty. And for those with severe frailty, loop diuretics should be continued for fluid overload only.
Oh, that's very interesting. And we've just had another talk about heart failure in the context of frailty at MIMS Learning Live Digital, delivered by Professor Raj Thakkar. And he said that if GPs over-optimise frail patients with guideline-directed medical therapies, which are based on evidence that excludes frailty, then they risk potentially causing harm, including falls and fractures. He has really interesting slides about specific types of medication and their effects in people with frailty, including beta blockers and aldosterone receptor antagonists such as spironolactone, and these are also called MRAs. So let's have a listen to what he said about MRAs in particular. For more context, you can watch the full presentation that this clip is taken from on the MIMS Learning website.
MRAs, so spironolactone, etc., they do lower blood pressure. They've got a pretty reasonable effect in patients who don't have frailty. But if you look at this study, total worsening heart failure effects, you might be hoodwinked into thinking, oh, MRAs are pretty good in frailty in terms of reducing worsening heart failure events. But we've just seen from Shirley's study and other studies that most hospitalizations in heart failure are due to non-cardiovascular issues. So even though this might reduce heart failure events, it might increase the risk of harm in terms of falls, fractures, AKI, etc. So just be super careful with MRAs in patients who have frailty.
That's good to have that recommendation. So it sounds like there is some consensus emerging within the medical profession about how to deprescribe for people with frailty, which should impact on their falls risk.
Yes, I hope so. And if people are encouraged to exercise more in the first place to keep their muscle mass and avoid sarcopenia, that'll also really help. It was interesting that in questions at the end of her presentation, Dr. Steele was asked about the top causes of falls in patients that she's seen recently in clinic. She said some were due to simple infections, but the majority were patients with frailty, sarcopenia, and cognition issues, for whom all the smaller bits adding up meant that they then went on to experience a fall.
And is there anything else beyond the exercise recommendations and the medication reviews that GPs can do to prevent falls in older people?
Another thing mentioned in the NICE guidance is considering surgical interventions where relevant. For example, referral for cataract surgery where relevant, and when people have experienced falls with an unexplained cause, investigating possible cardioinhibitory carotid sinus hypersensitivity as a cause with cardiac pacing if indicated. But to my mind, a lot of the other recommendations in the NICE guidance fall within the remit of health and social care professionals other than GPs. For example, home hazard interventions conducted by occupational therapists.
Yeah. And we have lots more education relevant to this issue on MIMS Learning that you might want to go and explore. For example, we've got red flags modules on the loss of consciousness and loss of vision, a module on polypharmacy in cardiorenal metabolic medicine, and another on polypharmacy in dementia.
And we have modules on alcohol misuse, delirium, transient ischemic attack, and of course, frailty itself. Dr. Alistair Robertson's clinical review on frailty provides a comprehensive look at what frailty is and how you can approach it in your practice. And he did a podcast for us that you can listen to as well. We'll provide signposts to the presentations we've talked about in this episode and the guidance from NICE and the BGS, as well as the deprescribing tools. What are our key takeaways from today? Well, first, Geriatrician Dr. Anna Steele recommends thinking of exercise as a drug for older patients, to be taken regularly at the correct dose and to be continued in order to feel the benefit in terms of mitigating falls. Second, some of the causes of falls we've heard about are infections, frailty, sarcopenia and cognition issues. But NICE warns that where there is no identifiable cause, it may be worth investigating possible cardioinhibitory carotid sinus hypersensitivity. Third, a variety of deprescribing tools are available which can help you to eliminate unnecessary falls risk. And the British Geriatrics Society says that antihypertensives should be stopped altogether in people with severe frailty. Thanks very much for joining me, Sangeeta, and thanks for listening to today's episode, sharing the wisdom of our expert writers and presenters. Don't forget you can claim a CPD certificate for listening to this episode. If you're on a podcast player, simply head over to the website version at mimslearning.co.uk and you can find key learning points there as well. We've been the MIMS Learning editorial team and this episode was produced by Jude Owen. Do join us next week for more podcast learning relevant to your work as a GP.